Demonstration is going to be of the lumbar spine. Depending on your clinical site and the protocol, you will either be doing a 2-view, a 3-view, or a 5-view lumbar spine. I'll be demonstrating all 5 views and the way the textbook recommends that you do this. There may be some variances at your clinical site, but the text you work with will show you that. So first of all, we're going to have our patient lay down in the supine position with his head to my left. So, Mr. Curtis, would you sit down here on the edge first? And then I'd like you to lay on your back with your head toward the pillow and your feet toward that end. Okay, thank you. Generally, when you have patients that come in and they're being x-rayed due to back pain, they're going to want to bend their legs, because being in a supine position accentuates the lordotic curve of the back and makes them more uncomfortable. So just by flexing the hips and knees, you take the normal lordotic curve and flatten it out. It's also best to then see the disc spaces between the lumbar vertebrae. So we do it for 2 reasons. Radiographically, it's better for imaging, and for patient comfort, flexing the hips and knees reduces the pain and strain on the back. We'll be doing AP first. So take a 14 by 17. And I'll be collimating to 7 by 17. So at 40-inch SID. So if I know I have 14 inches wide to begin with and I want to go down to 7, I am reducing 6 inches. So it's approximately 3 inches collimation from each side, and that's how you get down to your 7 by 17. Now that I'm centered and aligned, I'm going to detent. Oh, there we go, sorry. Detent it. And then I usually come to the head of the patient and I make sure that they appear to be, their midline appears to be down the midline of the table. He looks pretty straight to me. So I'm going to feel for his xiphoid tip and center on his mid-sagittal plane. And then I'm going to press in on his sides. Feeling for the top of his crest. Now I'm going to be centered at the crest or 1.5 inches above. And really that depends on the height of your patient. He's of average height, so I would probably center closer to the crest than I would above the crest, because you can see that the top of my light field is well above where his diaphragm would be. So if the crest is L4, 3, 2, 1, I want to include T12, and so I have T12 and L1 easily within the light field, and then down to a good portion of the sacrum. Okay, add my right marker. Lumbar spine imaging is shielding per department protocol. And keep in mind, we've got our L spine coming down, and then one of the things that we are also hoping to include is the SI joints. And because of that, if I place my marker at the bottom, I might have my marker end up in the SI joint. So for the lumbar spine AP, I'm going to put my marker at the top. I'll get the L spine and then the SI joints at the bottom. I am able to shield a male patient, so I'm going to go ahead and put the shield here. You can keep your legs bent. Okay. It's outside of the field of view, but I've shielded the gonads, mid-sagittal plane. His arms can either remain up on his chest or down at his side, and this is just on suspended respiration. So I'd have you stop breathing, and expose. Okay? Now, when you're doing a full 5-view L-spine, it includes 2 obliques. And because we're going to end up eventually on his left side, I'm going to do the RPO first, then the LPO, and then finish with the lateral. It's just a better sequence so that the patient's not rolling back and forth more than once. So I would like you to extend your right leg for me. I'm going to keep your left leg bent. And what I'm going to do, I want to control this motion of him rolling toward me, because if you ask a patient to roll towards you, they're likely to move their hips and now you're out of alignment. So I'm going to control this positioning maneuver. If you, please take your left arm and cross it over your chest. Now, I want you to roll all as one unit, don't move your hips. And I'm going to place the 45-degree angle sponge right under his back and then have him just rest against that. Now he can keep his arm up here, it's out of the way, or he can put it back down by his side, whatever is more comfortable. Now I've tipped him 45 degrees, but he's still in alignment. He hasn't shifted his shoulders or his pelvis. The collimation on this one is slightly different because we are giving ourselves a little bit more leeway side to side. So rather than being 7 by 17, I'm going to open this up to 11, and then I'm going to come down to about 14. So this is 11 by 14. Because I'm in an RPO, I'm going to keep my right marker on here. I'm going to feel for his crest again and ASIS. So ASIS, I'm going to come about 2 inches medial to that, and that should put me right on line with his spine. So if you can imagine reaching under and feeling his spine in the back, and where my fingertips end, it's going to be right on his spine. So it doesn't look like we're centered to mid-sagittal plane, but we are centered to his spine. Another way you can double check, if you come up here, if I imagine where his, turn your head just 45, if I imagine where his neck is, and I follow that down, that's also, and I believe maybe he's turned a little bit, that's why this is not lined up. So I follow his neck down, and I'm on his spine. So 11 by 14 collimation, 45 degrees to the RPO position. This I could easily shield for. Even on a female you could, because we've decreased our lengthwise collimation here. All right. And he would suspend breathing. Okay. Then I'm going to do this exact same position, but roll the other direction. All right, so bend your left knee for me again, and we're going to pull this sponge out. Okay, lay back flat on your back. And now I want you to bend your right knee and cross your right arm over your chest, and this time roll away from me. Okay, get on the 45-degree angle. And I'm positioning this so that it's halfway between, I have to move the pellet a little bit. It's supporting most of his torso and his pelvis. If you get it too low, when they lay back, their shoulders are rolled back. So I want to get this at least up to his level of his scapula. Okay, I've swapped out my 14 by 17 this time. Because I'm doing an LPO, I'm going to now put my left marker on, so I'm just gauging how far in I was before. No need to pull this out and recenter because the collimation is the same. I'm going to feel for crest and ASIS. Okay, slightly above the level of the crest and about 2 inches medial to the ASIS. And again, we can look at his spine and gauge that we're in the right position. So if I follow his spine down, I should be right on it. Okay, so suspend breathing and expose. All right, now I'm going to take this sponge out and I want you to slide back toward me just a little bit on the table so that you're not so close to the edge. So slide toward me. Okay, a little bit more. All right, now turn all the way up onto your left side. Now I want his hips, knees, and shoulders to all be on top of each other and his hips and shoulders in the same coronal plane. So what I need you, now if you had a patient that was not moving very well, what I can do to accomplish that is just twist the pad until his shoulders and his hips were going down the midline of the table. He's pretty mobile, so I'm going to have you bring your left shoulder back toward me. A little bit more with your shoulder, not your hips. A little bit back with your shoulder. Thank you. Okay, so now his shoulders, you can bring here. Now, another trick that I like to do, and I learned this from a long time CI from San Antonio Medical Center, was most people will say, oh, you know, put your hands in a praying position or in a sleeping position. Now, once you've done that, you're crossing this arm in front, and that actually rolls the shoulder forward. But if you tell a patient to lock arms like this, so if you tell a patient to lock arms like this, what that does is kind of block them, and now they're not going to roll forward because they've locked their elbows together. So I want to make sure that my shoulders and hips are in the same plane. Flexing the knees helps them balance. I would swap out my 14 by 17 for another 14 by 17. I'm going to go back down to the 7 by 17 collimation. All right, so 7 by 17. Now you have to imagine where the spine's going to end up. So there's a lordotic curve to it, so it's going to curve like this and then come back like this. So you would not want to put your marker right in the middle because that's the most anterior point of the spine. You either want to keep it proximal or distal. So I'm going to choose to put this distal, and my sacrum should be angling away from it. Center right on his mid-coronal plane at the iliac crest or 1.5 inches above, depending on the height of the patient. So here's his iliac crest. I'm going to center a little bit high because I absolutely want to include T12 on this, and I want to be on his mid-coronal plane. So what I would do, you're going to hear several tips and tricks for this. You can palpate ASIS and come back 3 to 4 inches. I like to come up and look at the spine, and I judge where his mastoid tip is, because remember, the cervical spine also has a lordotic curve, goes out to a kyphotic curve and comes back into a lordotic. So if I'm looking at the C-spine, I should be on the same coronal plane as his C-spine. And if I double checked and I palpated ASIS, I'm about 3 inches back. So they both work. You may hear other tips and tricks from your technologists. And then as he's sitting here right now, the only thing I might do is bring him just a little bit forward And again, you're going to get, the more of these you do, the more you'll understand the different types of body habitus and where to center. But that looks pretty good. One thing you're going to want to do on a lateral L spine and a lateral T spine, in addition to your gonadal shielding, we're also going to want to put lead shielding right behind the patient outside the field of view. Because this is a very thick body part, it's going to generate a lot of scatter, which can end up on your image receptor. So one of the things you can do to block the scatter is to put a lead shielding right behind the patient, and that will absorb the scatter radiation that his body is creating and prevent it from hitting the image receptor. So it drastically improves image quality. Okay, so we're set to go. I have him hold his breath and expose. Okay, now for our L5 S1 spot. Now, I said sometimes you do 2, 3, or 5 projections for the L spine. Sometimes on your lateral L spine, the L5 S1 junction is already open. And so you wouldn't need a spot film unless it was underpenetrated or not open. But most of the time, you still do need to do an L5 S1 spot. So I've got a smaller IR in here, and patient's on his left side, so I'm using a left marker. And then this collimation is quite small. It can be 5 by 5, 6 by 6, something like that. I'm coming down from 8, let's say, to a little less than 6, and from 10 to a little less than 6. So it's pretty much a square 5 by 5, 6 by 6 collimation, something like that, because I'm just looking at L5 and S1. Now you're also going to hear a lot of different positioning techniques to get the L5 S1. For me, if I grab the top of the pelvis with my hand and the distal phalanx of my third finger, if I place that on his ASIS and I place my hand at the top of his crest, I've created kind of a C shape, and I'm going to center right in the middle of that, pretending that if I carried this around, it would be a circle. So half the circle is created by my hand. If I made a circle, the X would be right in the middle of that circle. So ASIS, my hand on his crest, and actually what that ends up being, for the most part, is approximately, actually, I gotta go a little bit back. It's approximately 3 inches back and about 3 inches down. Now, depending on the size of your patient, that measurement is going to vary a little bit. Your book talks about it 3 and 3 or 4 and 4. I don't exactly remember, but again, the book is a guideline and you have to position based on your patient's body habitus. So I think that would get his L5 and his S1 right in my small field of view here. Okay, so I can shield anteriorly. Again, this is very thick body part, so I would want to put my lead shielding posteriorly to absorb scatter, and I would have him suspend breathing and expose. Okay, so when I was positioning for the lateral lumbar and the L5 S1 spot, I thought it would be better just to go over this part in your book. So on the lateral, you'll notice that they shot perpendicular when they placed a sponge. Now, on a patient that has a definite waistline, like you see this curved in, you either should put a small sponge at their waist, or you're going to angle 5 to 8 degrees caudad. My patient body habitus, he's pretty straight from the bottom of his scapula to his hips. And so because he doesn't, dent in right here like the patient in the book, I didn't feel that I needed to do a caudal angulation. So based on your patient's body habitus, what you want to make sure is that the interiliac line between the top of one iliac crest to the other is perpendicular. If it's not, if it's tilted a little bit, then you need to angle to match that interiliac line. Okay, for the L5-S1 spot, again, we're looking at this interiliac line, and if you feel like it is perpendicular to the tabletop, no angulation is necessary. If you have a very thin patient, or sometimes, pretty much on all women, you'll need at least a 5-degree caudal angulation, because their hips are broader. They tend to tilt in at the waist. But if you have a heavier patient or someone that has quite a bit of adipose tissue on either side, then you might need to angle slightly cephalad. But you determine that by looking at the interiliac line.